delighted that we have the honor of Dr. Gary Gibbons to be our medical grand round speaker today. Dr. Gibbons is the director of the National Heart, Lung, and Blood Institute at the NIH, which is the third largest institute at the NIH. Just a little bit of background on Dr. Gibbons. He got his undergraduate degree from Princeton, and then his medical degree from Harvard Medical School, and completed his residency and cardiology fellowship at Brigham and Women's Hospital in Boston. He then went on to faculty positions at Stanford University and at Harvard Medical School before joining the Morehouse School of Medicine in 1989, where he was the founding director of the Cardiovascular Research Institute and chair of the Department of Physiology at Morehouse. And he has developed an impressive portfolio of honors and research expertise. His area of focus in his research is in vascular biology, genomic medicine, and pathogenesis of vascular diseases. And he's really focused on the relationships between clinical behaviors, phenotypes, and social determinants on gene expression and their contribution to cardiovascular disease. He holds several patents for his innovations in the area of vascular medicine and in the pathogenesis of vascular disease. And he's gotten lots of honors throughout his career. He was elected to the Institute of Medicine. He was selected as a Robert Wood Johnson Minority Faculty Development Awardee, a Pew Foundation biomedical researcher, and an established investigator of the American Heart Association. And since being at NHLBI, he's really put a lot of focus in fundamental discovery science. And I've been fortunate to interact with Dr. Gibbons through my role in the American Thoracic Society over the years. And what really impresses me about Dr. Gibbons is his commitment to nurturing the next generation of scientists, and has made the NHLBI be a leader in developing novel and innovative ways to ensure the success of our next generation through the development of novel mechanisms in the Career Development Awards, Loan Repayment Awards, helping facilitate developing mechanisms to facilitate the transition to Independent Research Awards. And it makes me proud to be a part of the NHLBI. He is also extraordinarily committed to ensuring diversity in medicine and working towards increasing the workforce, as well as working towards understanding what we can do for healthcare disparities. Oh, and he has arrived. Excellent. So, as part of his commitment to training the next generation, Dr. Gibbons also has agreed to do a session after Grand Rounds to talk with our residents and trainees about career development, and very thankful and excited about that. So with that introduction, I will hand it over to Dr. Gibbons for his talk on advancing precision medicine for health equity and public health impact. Thank you. You're muted.
He's not muted. Gary, can you hear us? We unfortunately cannot hear you.
Yeah, I don't see the microphone next to his name, so I think there's somehow need to hook up your audio.
Dr. Gibbons, if you on the lower bottom, you should see should be a little microphone. You can select a microphone from your computer. This will be on the WebEx screen.
No, I'm unmuted on my side.
Yep. You're coming
now
in.
We hear you.
Okay. All right. Thank you. Well,
Have a great talk.
all right, thank you. I appreciate that generous introduction. My pleasure to join you despite the virtual meeting glitches of signing on. Real pleasure to visit with you virtually. And if I could have my next slide. Part of what I would like to do is probably an atypical grand rounds, but give you from the perspective of director of the NHLBI, some of the both challenges and opportunities we see before us to fulfill our mission. And this is a position of privilege of public service in which we work for you in the public interest to advance the mission of discovery science that enhances the human health. And we've tried to do that during my tenure following these enduring principles, principally, as Dr. Schnapp pointed out, to value investigator-initiated fundamental discovery science is the real core foundation of our investments and our means of advancing science. And to do so by maintaining a balanced portfolio that spans the spectrum of basic, translational, clinical, population, and community-based research. And as was mentioned, we have a deep and abiding commitment in training a diverse new generation of leaders in science, as well as supporting an important area that's been often underinvested in, and that's to support implementation science that empowers patients and enables partners to improve the health of the nation in real-world settings. And to innovate an evidence-based elimination of health inequities, both in this country and around the world. Next slide, please. We tried to do that first by being accountable stewards as public servants in promoting investigator-initiated discovery science. On the left, you can see that since we began in 2012, we've managed to boost and maintain a steady R01 success rate overall that is in the mid to low 20s, and we believe that is at the vanguard of NIH overall. With similarly important for the next generation is our early stage investigator pay line, which is a 10-point bonus, and in general has resulted in a success rate for early stage investigators that's been in the high 20s to low 30s over the last several years, trying to give predictable encouragement to our early stage investigators. Next slide, please. In that regard, we're also promoting diversity and inclusive excellence in the biomedical workforce that recognizes that talent comes from lots of places and is throughout our society, and that our biomedical workforce should leverage that diversity and reflect the greatness of our country and its diversity. In that regard, our portfolio has a certain spread to it demographically, as shown on this slide by sex and gender. You can see early parts of the pipeline of trainees. We're almost at parity in terms of gender, sex in our development and trainee awards, Fs and Ks. And we're making progress with regard to our R01s, particularly on the early stage investigators. And this cohort, we hope, will help change and extend the diversity of our overall R01 pool as this cohort moves forward. Similarly, we have smaller numbers, but in terms of race ethnicity, you can see the relatively modest proportion of all R01s. But again, that same trend where the earlier pipeline of trainees, Fs, Ks, Ts, etc., are more diverse and inclusive in following with inclusive excellence. And we see promise in expanding diversity and inclusion and inclusive excellence in our early stage investigators. Again, part of the reason why we emphasize the importance of maintaining a large ESI pool, not only for its excellence and its promotion of the next generation, but indeed because it is perhaps our greatest place of inclusive excellence. Next slide, please. Toward that end, we have a real portfolio of various programs along that pipeline that I won't detail today, but there are many stepping stones to success. And in particular, I wanted to point out to the University of Wisconsin audience here the Faculty Development Awards, a recent one by NIGMS called Mosaic, which is trying to maximize opportunities for scientific and academic independence careers, basically a K99 or 00 type award that, again, promotes inclusive excellence and diversity. And then similarly, out of the Common Fund, a trans NIH effort that is a co-investment in faculty institutional recruitment for sustainable transformation that again promotes inclusive excellence and partners with institutions to develop the kind of recruitment packages and cohorts necessary for institutions to expand the diversity of the professoriate and thereby the biomedical workforce for the NIH. So we're very excited about the launch of those programs over the last year. Next slide, please. I'd like to shift to the scientific opportunities that lay before us with sort of three sort of vignettes and themes. One meant to be somewhat timely, related to what we're all facing in this COVID-19 pandemic, and how the NIH and NHLBI has developed strategies to address its impact. And following along that, a certain theme that relates to addressing health disparities, not only in COVID-19, but in other elements of our mission portfolio. In this case, one example from lung, pulmonary disease, asthma, and then cardiovascular. Next slide, please. Toward this end, I don't need to tell this audience that is at the front lines of addressing COVID-19 in your daily practice, that the NIH is, particularly the NHLBI, found itself on the front lines of this battle with you very early on, over a year ago, when it was quite clear that the SARS-CoV-2 virus obviously was spread as a respiratory virus and therefore affected the lungs, but also because of its tropism and receptors elsewhere in the body. It could injure the heart, and particularly the lining of the blood vessels that go throughout the body. And that's contributed to the sort of multi-organ effects of this COVID-19. And accordingly, we've developed a real full court press and comprehensive portfolio to address it that spans the spectrum of achieving a number of goals and controlling and eventually ending this pandemic. First, initially, we started with last year was to reduce the case severity and fatality and speed recovery. And therefore, we were focused in on host-directed therapeutics in clinical trials that, again, align with our mission areas. Similarly, understanding the short and long-term trajectory of SARS-CoV-2 infection, leveraging our legacy observational longitudinal studies. Thirdly, to better understand these diseases and enable risk stratification with precision intervention. And so we've embedded a translational preclinical study component to our overall response. This is aligned with an opportunity to identify biomarkers and potentially new therapeutic targets, either from repurposed drugs or novel therapeutics, and developing the platforms to deliver those. And then finally, target populations most severely affected by COVID-19 and develop community engaged research strategies to address the pandemic in that way. Next slide, please. Toward this end, we've the NHLBI working in collaboration in a trans NIH effort called ACTIVE, in which we've moved rapidly to address clinical science questions that could enhance patient care of those affected by COVID-19 across the full clinical spectrum of sort of early symptomatic elements toward progressing into the need for emergency room visits or hospitalizations, ICU care, and ultimately recovery. And so we've developed a clinical trial portfolio that brings together basically all our clinical trial assets in an unprecedented way that actually links the blood divisions clinical trial apparatus with the lung divisions, with the heart divisions in what we call connects that goes across the institutes and has developed adaptive, nimble master protocols to rapidly test promising therapeutics and find out pretty quickly what's working and what's not. And we think this has been very effective, as shown here in the blue as part of the overall trans-NIH effort. We've focused our assets and our mission on certain areas, particularly related to the early observations of a coagulopathy that was associated with COVID-19, and therefore developing a variety of antithrombotic strategies to address this early complications in which, we were seeing patients very early on with both venous thromboses, arterial thromboses, large vessels, small vessels, indicative of the fact we believe that this virus specifically attacks the lining of the endothelium, the ACE2 receptor, and therefore modulates the coagulation cascade and thrombogenicity. Similarly, as part of our blood transfusion program, we've been interested in passive immunization, particularly with convalescent plasma, as well as various host-directed anti-inflammatory sorts of interventions that might modify the course of the disease. As shown here in blue, we have protocols currently underway, Active 4B, looking at antithrombotics in the outpatient basis, Active 4C in the recovery phase, in which we're still seeing lingering effects of that coagulopathy after the post-acute infection is resolved, and we're testing therapeutic strategies of what to do with those patients. Early on, we attacked in Active 4A the question of how best to prevent those thrombotic complications in hospitalized patients. That study has been read out now, and in which there's clearly evidence for those with a moderate COVID-19 in hospitalized patients, the benefit of full dose anticoagulation with heparin relative to prophylactic dose as showing benefit. And yet, we still have yet to see and define an antithrombotic strategy that has shown benefit in severe COVID-19 patients. And that is indeed what the protocol has now turned to in moving forward. Similarly, the NHLBI apparatus participated in Active 3 that tested neutralizing recombinant monoclonal antibodies directed against the virus very early on, and again provided important insights that strategy, particularly in hospitalized patients, has not particularly panned out to be effective. Several neutral studies with different recombinant agents have proven there. And it's apparent now that the greater efficacy of that approach might be in the pre-hospital earlier stages in the progression of the COVID-19. Similarly, our platform took on the question of passive immunity throughout last year. There are literally tens of thousands of units of convalescent plasma being administered to try to treat COVID-19. Convalescent plasma has been around for over a century, and yet, surprise to me as a cardiologist, it was based on actually relatively little randomized controlled trial data to actually prove the efficacy of convalescent plasma. So even though it was intuitively appealing as an option, it really had not been rigorously shown. And now our platform, the C3PO, has documented futility in the outpatient setting. And that's consistent with other reports on the inpatient setting where there's a lack of efficacy of convalescent plasma in changing outcomes in COVID-19. So it's important in all these cases to understand what's working and what's not working to provide better guidance and evidence-based patient care for these patients as we learn more and more about this novel coronavirus and try to reduce case fatality. Similarly, our institute supported the U.S. Arm of a study, Corona, that looked at colchicine, and indeed some intriguing data on, again, an outpatient basis that suggested that it may have some effects in attenuating progression in the outpatient setting. Similarly, the platform of the NHLBI, particularly the PEDAL network, very early on advanced the question of whether hydroxychloroquine had any efficacy. And I might say this study was proposed to us, as I recall, in late March, and by April, it had been peer-reviewed and assessed as that proposal, IRB and DSMB approved, launched, such that that question was asked and answered by June. And so in really a stunning rapid time, the platform was able to address an important and controversial question in the spring of 2020 about hydroxychloroquine. So that just gives you a summary of some of the things we've been supporting to try to address host-directed therapeutics in the COVID-19. Next slide, please. So one of the more recent things we've learned about this virus, it seems to teach us something new every month or two, relates to the notion that there are post-acute sequelae of COVID-19. And it appears that even after the acute infection has resolved and maybe the virus is barely detectable in the body, there are many patients who have persistent symptoms that may not completely resolve and persist. And it doesn't always correlate with the severity of the acute COVID-19. So even those who had a mild experience with acute COVID, nevertheless, have a debilitating, in some cases, syndrome that's characterized by fatigue, decline in the quality of life, functionality, often sleep disturbances, anxiety, depression, cognitive disturbances, this notion of long COVID, long hauler brain fog, and other sequelae of cardiopulmonary effects, persistent dyspnea, palpitations, dysautonomia, and other sequelae. And so we're still trying to understand the long-term implications of infections with SARS-CoV-2, and therefore we're pleased that NHLBI has been charged with being at the lead in collaboration with NINDS and NIAID to pursue a trans-NIH initiative related to post-acute sequelae of COVID-19. Next slide, please. In brief, the approach will be to use a number of strategies and streams of data to establish, and participants to establish a SARS-CoV-2 recovery clinical study, or a cohort, if you will, that will be, in essence, a meta cohort of patients who come in and have acute COVID-19, and that we prospectively follow to see who develops the syndrome of post-acute sequelae of COVID-19 and who does not, as well as a direct outreach and a case finding to those who are already experiencing post-acute COVID symptoms, and really capture the full broad spectrum of this phenomenon to understand both PASC as well as those who don't develop PASC as part of this, and do then systematic clinical phenotyping and characterization at various levels of depth of imaging, immunophenotyping, et cetera, with the hope that we can identify what's the incidence and prevalence of PASC, the risk factors, biomarkers, and potentially identify the potential for interventions, targeted ones, by using control protocol elements, and then carefully characterizing these recovery phenotypes. Next slide, please. So this is particularly, I think, critical in our response as we recognize the disparate impact of COVID-19 on communities of color that you're all undoubtedly familiar with. As shown on the right, you can see here for this particular one is on hospitalizations, where you can see dramatic disparities of populations that are most adversely affected by the pandemic: American Indians, Latinos, African Americans, relative to Asians and whites. And this is probably multifactorial insofar as it probably reflects to a large extent the high exposure to SARS-CoV-2 infection that comes from the preponderance of people of color in essential service work, whether it's transportation or restaurants or grocery stores and hospitals in frontline service positions where there's less flexibility for protection, maybe less access to protective personal equipment, as well as less adaptive flexibility in being able to protect yourself at work, such as in meatpacking facilities and workplaces, or to shelter in place remotely due to the nature of that work, not necessarily being white collar, much like many of us. Similarly, we recognize that severe COVID has been problematic in these same communities, in part related to the high prevalence of underlying health conditions pre-COVID that predispose to severe COVID, such as cardiovascular disease, chronic lung disease, obesity, diabetes, which we know is very prevalent in these same communities. Clearly, there are also dimensions of the social determinants of health and access to testing, treatment, contact tracing, and more recently, vaccines that play a role in promoting and sustaining, perpetuating these health inequities. Next slide, please. Toward that end, as part of our response, we are pleased that Dr. Collins turned to the NHLBI and the National Institute of Minority Health Disparities, my colleague, Dr. Peristabla, to co-chair a trans NIH initiative that would take a community engagement approach and community engaged research approach to addressing the disparate impact of COVID-19 in communities of color. And so we've launched the SEAL initiative, Community Engaged Alliance Against COVID-19 Disparities, in which we targeted a solicitation to communities at highest risk, some of that beginning in the early phases last year, when it was particularly problematic in the Southwest and Southeast in communities of color. And more recently, we've moved towards solicitation in other areas that are now affected more broadly across the country, particularly again in the Southwest. You can see in that lighter blue, the Midwest and the Northeast that had not been captured in our first wave. These SEAL teams are really on the ground. They are working as coalitions of academic partners, community-based organizations, healthcare centers and providers, faith-based organizations, in conjunction with state and local health departments and government agencies, in a real, again, coordinated, collaborative partnership strategy to address how and work with communities to see how best to protect them in the pandemic from preventive, diagnostic, therapeutic, inclusive participation in trials, as well as ultimately now vaccination and uptake with confidence and delivery. So this SEAL operation has been active. Next slide. And just as exemplars in this process of creating a community of practice through collaborative partnerships, these SEAL teams are working on the ground, establishing partnerships within communities. In particular, for example, the Florida SEAL team partnered with emergency management and local churches to really host vaccine drives very recently. Similarly, we recognize that a key part of addressing the pandemic in communities of color is to address misinformation and mistrust within these communities. And a critical strategy toward doing that is to develop and establish evidence-based authoritative information that is delivered in messages and pathways that resonate within these communities and delivered by trusted and trustworthy messengers who carry those authentic and fact-based messages. And that's been a big part of the strategy throughout this SEAL operation. Indeed, there have been a variety of novel strategies taken. For example, Michigan and North Carolina did a sort of crowdsourcing of messaging in which the community itself was able to come up with language and ideas that resonate within those communities to nudge them toward action. Again, in their own voice, in their own way, and tapping into that wisdom and insight of communities. And we found that that's been very effective in addressing misinformation and mistrust. Similarly, there's been almost a drumbeat of fostering and understanding a trust in science that has involved a lot of outreach, a lot of town halls, community forums, engagement by on-the-ground community health workers working at the local level, delivering these messages in ways that can target these at-risk groups. And finally, accelerating the uptake of beneficial interventions through a variety of means throughout that are having an impact, where clearly messages are being delivered to hundreds of thousands, indeed perhaps millions of individuals through these outreach efforts that appear to be bending the curve. Next slide, please. Indeed, we're encouraged that after launching in August, September, where there was clearly deep mistrust and a lot of misinformation, this drumbeat of activity, this engagement of both local and national stakeholders, particularly those led by minority groups, African American, American Indian, Asian American, Pacific Islanders, all these collaborative groups working collectively at multiple levels, I believe has contributed to bending this curve. And you can see the major gap that existed with African Americans, particularly being those least prone to get vaccinated, that way back in September, that's now turned around dramatically. The gap has closed in terms of that hesitancy. And again, we're encouraged that there's a momentum that suggests that hopefully we can address the disparities that exist in such that the science that's going to end this pandemic actually penetrates and is taken up by communities most adversely affected. Next slide, please. So let me pivot from COVID to another part of our portfolio, in this case, addressing health disparities in asthma. Next slide, please. In which this audience is very familiar with the fact that there are race ethnic disparities in the prevalence of asthma, particularly in African American and Latino communities, particularly among children, where there's a leading cause of disability and lost school days, and a challenge where indeed there's this dynamic interplay between the social determinants of health and perhaps genetic and biological predisposition and other stressors that can promote this higher prevalence and higher levels of hospitalization, indeed higher mortality in these communities. Some of that may relate to the context of the air quality, air pollution, housing characteristics that are part of the social determinants of health, the relative lack of green space in some of these communities, and their access to a healthy lifestyle. And the consequences of residential segregation for many generations. Next slide, please. So as we're trying to address these issues, we recognize that there are historical challenges. And one that as a cardiologist, I was somewhat stunned to see and understand. Many of us are familiar with sort of algorithms of race-based reference standards. And we know historically in medicine, this has often been based on studies sometimes of medical students in the middle of the last century that oftentimes was white males as the reference for many of our medical references. This one for lungs has existed for many, many years. Indeed, some of the earliest studies were done in the Civil War in comparing lung function of white soldiers who served relative to black soldiers. And there's been this long-standing belief that white males have the greatest lung function and capacity as compared to other racial ethnic groups. And it may not surprise us with the lens of 2020 that this may reflect in part a certain racial hierarchy concept that's really embedded in the European classification of race that goes back a century or two, in which white individuals were considered superior in all ways to those communities of color. And this is borne out in some sense by the studies that have been done over the years, where you can see in the middle panel that many of the studies attributed and interpreted the data to reflect this sense of race, not as a social construct, but as a biological construct that was indeed hierarchical, in which the presumption was that if there were racial differences in the 1920s, it reflect inherent properties of race and to some degree anthropometrics. What's notable, as you can see over time, including to the current day, that we, with perhaps a more objective framework and recognizing race as a social construct, now appreciate that much of the variance is unexplained, and that a modest amount may relate to anthropometric differences across race ancestry, but the component that is quote unquote inherently biological related to race still seems modest and needs further characterization. And so this is part of the backdrop that whenever we talk about racial ancestral differences, disparities of outcome, and health equity, that we appreciate how the lens of those who do the research and interpret the findings and bring their own inherent, if not unconscious biases to the data can influence actually how we practice medicine. Next slide, please. It's notable that none of those studies, for the most part, included the social determinants of health as potential covariates of that variance. And in this regard, it's kind of notable that here's the work of Dr. Esteban Burchard, UCSF, in which he looked at a genetic association study at this one of the levels of pulmonary function and was able to identify in a Latino population a locus that appeared to be significantly associated with, in this case, lung volume, and identified a pathway that may be promoting inflammation in the lung and might constitute some sense of a mediator pathway that might pretend differences by race ancestry in terms of susceptibility to asthma and or its clinical course. Next slide, please. Toward that end, I believe that ultimately we hope that we can move beyond skin color and 18th century characterizations of the human family toward precision medicine, where we allow both the biological and social variables to refine our ability as clinicians to identify those at most risk and or to subphenotype or subgroup individuals most likely to respond to targeted therapies. And this is beginning to happen in asthma, where screening, particularly for those with severe asthma, starting to identify biomarkers. In this case, elevated eosinophilia that's associated with a certain cytokine profile related to IL-4 and IL-11. And now with new technologies, able to target these pathways in ways that modifies the course of the disease. So we think there's a very promising area in which precision medicine will hopefully take us beyond a sort of superficial and overly simplistic race-based strategy to care for all our patients. In that regard, the NHLBI is supporting the PRECISE study, which is further extending this paradigm, and in particular, we'll be looking at IL-6 as a marker of severe asthma. Next slide, please. I believe some of our co-investigators are at Wisconsin. So finally, I'll close with a challenge that we have that I think also represents an opportunity in our cardiovascular disease portfolio. Next slide. In which we appreciate, again, this theme in which we recognize certain health disparities and the importance of social determinants of factors in influencing health outcomes. And in that regard, this is data from the NHLBI's Cardia study that looked at young adults. It's a biracial cohort. And this particular observation was to look at neighborhood level racial segregation and followed individuals through the trajectory of from childhood and young adulthood onward. And in essence, observed that individuals who began their early life in racially segregated neighborhoods and remained in racially segregated neighborhoods tended to have a higher blood pressure than those who started off in racially segregated neighborhoods, but then moved toward more integrated settings, those individuals having a somewhat lower blood pressure trajectory. And again, suggesting that perhaps the environment associated with racial segregation was influencing the trajectory of disease over time. And indeed, we recognize increasingly that cardiovascular health reflects a trajectory of many decades, some of which probably begins in utero. And therefore, that slope of that trajectory through childhood and childhood exposures may be critical. Next slide, please. Just to hopefully give a little bit of local flavor, albeit not in Madison, but in Milwaukee, we're starting to appreciate how those patterns of racial segregation and the social context that they start to define and the environmental exposures they start to promote can influence that lifelong trajectory. And this is just one example. Many of you are aware of the historical policy and practice of so-called redlining, where literally laws started to influence the access to capital and investment by neighborhood. And on the left panel is back to the redlining policies in 1938, I believe, in Milwaukee. And you can see the red areas were the areas that it was discouraged to give credit, and as opposed to the others that were allowed to build, get housing loans, and develop what we all know is the major pathway to wealth in America, home ownership. That, as you can imagine, had some socioeconomic impact with what appears to be a striking correlation between some of those red zone and redlining areas with present day socioeconomic status by zip code, in which you can see many of the same communities are the ones that are impoverished, that were literally red line to be impoverished and underinvested in 1940 to this day in a multi-generational way that influences multi-generational wealth and access to capital investment that's had a life consequence, as shown on the right-hand side, where you can see, again, these correlations that of life expectancy, yellow being lower in that same area. Again, suggestive of the potential importance of social determinants of health. Investigators like Nancy Krieger and David Williams have analyzed this more rigorously to define these interrelationships. Next slide, please. This is where we appreciate that where you live can get under the skin and affect health and biology. Again, to give local flavor here a bit, we see clear racial disparities in cardiovascular health and in alignment with segregation that's so typical of cities. And I hope it's appreciated. I'm not in any way picking on Milwaukee. It's a sad part of my giving talks to academic institutions all over the country that it's actually not difficult to actually find data almost no matter where I speak that aligns with this result. And we're starting to appreciate that racial segregation, socioeconomic status starts to create an environment that is not heart healthy, where there are food deserts, where there's less access to a healthy lifestyle, and where there are other stressors of food insecurity and financial insecurity, all of which may get under the skin and modulate biological systems, whether it's your microbiome, your metabolome, your immune system, your epigenome, that changes biological systems in ways that can influence the trajectory of diseases like hypertension and heart failure. And that's why we believe we need a real multidimensional appreciation of the various factors that influence health that are inclusive of both genetic, biological, as well as social. Next slide, please. Toward this end in heart failure, there's already evidence here in this particular paper that, again, links the outcomes of heart failure to where you live. And indeed, the likelihood of exacerbations, in this case, correlating with living in a food desert. Living in a food desert obviously may relate to your insurance access, your access to quality care, elements that might influence your health literacy, your educational opportunities, all of which can conspire to produce disparities in outcome and in incidence. Next slide, please. In that regard, we also recognize from NHLBI studies that trajectory can be modulated by lifestyle factors. And so here's the Jackson Heart Study, the largest epidemiologic study of African Americans in the country. It shows here that the prevention of heart failure may have a pathway in which those who adopt the simple 7, that is increasing physical activity, losing weight, having a healthy diet with fruits and vegetables, controlling cholesterol, managing blood pressure, reducing blood sugar, stopping smoking, it can indeed predispose to better outcomes over time in this longitudinal study, suggesting that perhaps interventions along these lines may be able to modulate the incidence of these disparities. Next slide, please. Indeed, we're recognizing that the NHLBI supported research developed the DASH diet, rich in fruits and vegetables, has been shown to lower blood pressure. And indeed, recently, the mechanisms of that are starting to become clear in the sense that it appears to modulate the microbiome and indeed the metabolome, such that the metabolome is clearly distinct in those who get the DASH diet versus others. And we're recognizing from preclinical studies that those metabolites can be important and powerful modulators of the immune system and other pathobiological pathways. And so therefore, it's not surprising, perhaps, that if you look at heart failure with preserved ejection fraction, that those who took a diet that's more DASH-like actually had better, more favorable changes in their ventricular arterial coupling and arterial stiffness, both factors that might influence the course of HFpEF. Next slide, please. So I believe in this vignette, we may have an opportunity to influence, in this case, the course of hypertension and heart failure through interventions that can be transformative in at-risk communities. Multi-level approach for preempting heart failure, in which community engaged research may reach out to areas that can improve both health literacy about prevention and adoption of those behaviors that influence risk. This has already been done in an NHLBI-funded study by Ron Victor, published in the New England Journal, in which he tapped into the wisdom of communities and recognized that barbershops in African American communities are major aggregation points for African American men and a channel for communicating health information and indeed getting your blood pressure checked. And he used this model to actually show improved hypertension control in these communities using this approach. If you then do that with the NHLBI-funded studies that have shown leveraging mobile health technologies, that indeed there are ways that we can reach into these communities and change the trajectory. Next slide. Let me just close by the challenge of redefining heart failure and moving beyond just ejection fraction. The clinicians in the audience recognize that heart failure is really a complex multi-organ, almost syndrome in some ways, and that we have a very loose and less than rigorous definition just based on the squeezing function seen on an echo. And indeed, that it's become a wastebasket, probably of a number of subphenotypes, both reduced ejection fraction and preserved ejection fraction. And clearly, we need a new taxonomy. We need to reclassify, deconvolute what heart failure is. The fact that many studies now have been neutral in terms of finding effective treatments of heart failure with preserved ejection fraction really is a call to action to redouble our efforts to better understand this disease and develop better targeted therapies. Next slide, please. Toward that end, again, we think that there may be opportunities to identify novel targets using genomic strategies. There's just one example of genetic association studies in heart failure, in which one pathway is identified that appears to be an important transcription factor for cardiac development that might also predispose to atrial fibrillation, which the clinicians will recognize is often a kind of chicken and egg, where sometimes atrial fibrillation may presage and precede heart failure. Sometimes it may be a consequence. And so the notions that something affects the structure developmentally of the heart could predispose to both those is indeed intriguing. So this offers promise. But I must point out that this large-scale study was limited by the fact that it nearly was entirely Eurocentric, had very little diversity, and also was inclusive of a variety of subphenotypes of heart failure, all put together. And so that undoubtedly undermined its ability to really understand the different flavors and types of heart failure, if you will. Next slide, please. In that regard, we're encouraged by the emerging promise of polygenic risk scores that appreciate the complexity of the genetic architecture of complex traits and recognize that perhaps in contrast to a monogenic, highly penetrant variant, that these complex traits may reflect variations in a number of different genes that in aggregate cumulatively add together to identify individuals at highest risk at the extremes of the distribution. And this is a promising technique for the future that's already shown some promise. Next slide. One of the challenges of those polygenic risk scores, however, is again, if they are developed and modeled and tuned and trained based on Eurocentric populations of genomic resources, that they will be most effective, primarily for those it was referenced on. And indeed, that's how it's played out yet again. You can see on the left the genomic resources and how much of it is concentrated on individuals of European ancestry relative to other ancestries that are actually the majority of the human family. And performance of those polygenic risk scores outside of Eurocentric populations is actually pretty dismal and problematic. And so clearly the field lacks diversity and inclusion in these large genomic resources, and this is a major problem for the field, and particularly its capacity to translate into precision medicine. Next slide, please. I'll try to wrap up here quickly. This is part of the motivation for our Top Med program that now has over 150,000 whole genomes reflective of a diverse population that builds on our diverse clinical and legacy longitudinal cohorts. And you can see the diversity in which actually European ancestry is the minority, and that was intentional to expand inclusivity of these resources and to expand their generalizability to our entire nation as a result. And this is not something we did for political correctness, but rather because it's scientifically rigorous. To understand the human family, it's important to study all the variation in the human family, and indeed to ignore the greater amount of genomic variation in ancestry, particularly African ancestry, is almost malpractice scientifically. And so this is a critical part of our strategy, and you can see the diversity of phenotypes. Similarly, I should note that these are multi-dimensional data sets that not only include the DNA variation, but the social determinants of health, behavioral characteristics, and it's in doing so we believe this will be effective in understanding the determinants of health across all populations. Next slide, please. It's already paying off. A key part of this was to develop an imputation server that's on Top Med that's reflective of the diversity of the human family. And as a result, relative to other reference panels, it has dramatically increased the rigor and effectiveness of understanding genomic variation across ancestral groups, and particularly imputation studies, methods, and applications. Next slide, please. In many ways, this has really democratized genomic research. And then finally, we not only had the opportunity to go from whole genome sequencing, but down to the molecular level at single cell resolution. And we believe that this will be critical in deconvoluting the diagnosis of heart failure, as shown here, where you can see subtle differences based on the chamber as to specific gene expression profiles and how they're affected both in health and disease. And we believe this will be critical to understanding the subphenotypes and molecular pathways of a complex entity like heart failure. Next slide. Toward that end, we're starting to see some promising data emerge in which these technologies can clearly develop gene expression profiles to distinguish heart failure with preserved ejection fraction versus reduced ejection fraction, and identify distinct molecular pathways, as well as have prognostic implications in terms of precision medicine and outcomes as shown on the right. Next slide, please. And that gives us great hope about what we're developing with regard to this a resource, a cloud-based resource that should be accessible to all, that includes these Top Med data and Biodata Catalyst, the platform to see, share, analyze these data, and use modern analytics to do so in an integrative fashion. Next slide, please. So what I've tried to share, and I wrap up here, is in essence kind of a what if of precision prevention. that could change the trajectory of heart failure for high public health impact, and one that is able to target those highest risk, like Carla here, 50-year-old African-American woman with hypertension and a low simple 7 score, who lives in perhaps an African-American community in Milwaukee, who carries maybe a high risk polygenic risk score as we evolve that technology. And her clinicians hopefully can partner with community-based resources to not only give her a prescription in the clinic, but also a prescription that she can execute where she lives in the real world, in which maybe she can interact with peer-led health education, health workers that can help her with preventive health lifestyles, help her with her diet, her physical activity, perhaps mHealth technologies that can again promote her adherence to that lifestyle, and in some ways start to modify that trajectory such that she has a more healthy profile, and one in which perhaps if we came back 10 or 15 years later, we may have been able to prevent that heart failure and those disparities. Next slide. So just to close, this is the vision we see in the future. By advancing our portfolio collectively with our circle of partners. You are the mediators of our mission, and we look forward to collaborating with you to create this diverse, connected community committed to improving health for all communities. Thank you for your attention.
Great. Thank you so much, Dr. Gibbons, for a really wonderful overview of what the NIH is currently doing, and going from a DNA all the way through to community, and how we can use all of the information we have to better the health of all of our communities throughout the United States and ultimately throughout the world. We are over time, and I want to make sure that Dr. Gibbons gets a chance to talk with our trainees, which he is scheduled to do next. And I will volunteer Dr. Gibbons, because I'm sure if anybody here has questions, you can email him at the NIH. I would like to impress upon all of our attendees, especially our junior folks, the NIH is your advocate. The folks there are really our supporters and sponsors and are there to help. So thank you again, Dr. Gibbons, and I look forward to seeing you in person at some point in the near future.
Absolutely. Thank you.
All right, take care.
All right.